Welcome, and thank you for joining us to those who are joining the recording. We're excited to present the first registrant webinar as an amalgamated college, regulating 9 professions, and to see this interest. My name is Kathy Davidson. I'm a staff member here at CHCPBC, and I'll be in the back end helping with the technology issues and curating the questions we receive. Susan Paul from CHCPBC is also here to facilitate today's discussion. In a moment, I'll introduce our speakers, but we'd like to begin today's webinar with an acknowledgement of whose territories the offices of CHCPBC are located in. We have 2 offices, one in Vancouver and one in Victoria. Did I say CPTBC a minute ago? Sorry. CHCPBC's Vancouver office is located on the unceded and stolen territories of the Hunkaminam-speaking peoples, the Musqueam and Tsleil-Waututh nations, and the Squamish-Snatcham speaking peoples of the Squamish Nation. The CHCPBC office in Victoria is located on the unceded and stolen territories of the Lekwungen peoples, represented today by the Songhees and Esquimalt nations, and the Wasanich peoples who speak Senchothan, including the Pakwachin, Saud, Sartlip, and Sakum nations. These First Nations have maintained a special relationship with the lands and waters for thousands of years since time immemorial, and that relationship continues today. I'm now very pleased to introduce Dr. Rebekah Eatmon, a family physician, and Robin Roots, who's a physical therapist. Professionally, they have worked side by side providing healthcare services in Northern Indigenous communities, and I will leave them to tell us more about themselves in their good way. I will now turn off my webcam and leave Dr. Rebekah, Robin, and Susan to start the conversation.
Thank you so much, Kathy. So I'll just get started and introduce myself. So I'm Dr. Rebekah Eatmon. I'm Tsimshian from Wakwalam on my dad's side, from the Raven clan. And on my mom's side, I'm Métis. Our family name is Gonville, and our roots go back to the Red River settlement. And I'm currently a family physician practicing in a few different places. So I work at St. Paul's doing primary care, OB, and perinatal substance use. And then I get to work with Robin up north in 2 very remote Indigenous communities called Takla and Yukuche. And then I also work with urban Indigenous populations in Vancouver. And I also just wanted to share like what brings me to this kind of work and why I do these kind of webinars as well. So just as an Indigenous person, I've unfortunately had the opportunity to see racism in our healthcare system, and also the inequities that my family members face as Indigenous people living in remote communities in BC. And so I like doing this work because I feel like in general, like healthcare professions are caring professions, and a lot of us have gone into it because we want to do good, we want to do the right thing, and I just hope that we can provide some pointers today in order to do that. And I'll pass it over to Robin.
Thank you, Dr. Rebekah. So hello, everyone. So I'm Robin. I'm a settler of Scottish and English ancestry. I'm very grateful to be joining today from the ancestral and unceded territory of the Lheidli T'enneh, known colonially as Prince George. In DeKalb, it means where the rivers meet, referring to the Fraser and the Nechako, the people of the 2 rivers. And as Kathy mentioned, I'm a physio. I'm also faculty in the Department of Physical Therapy at UBC, and I'm clinical lead for the Masters of Physical Therapy North. Clinically, my experience has always been in rural, northern, and remote communities, and so I've been very fortunate to work with and learn from patients, but also work alongside many wonderful teams and teams of physicians. And Dr. Rebekah and I work, as she mentioned, in a primary care team. When I first met Rebekah when she was a resident as part of the Indigenous Family Practice Residency Program, and Dr. John Polovich brought Rebekah up to Takla, and so we met in a remote First Nations community and developed certainly that connection at that time, and have collaborated on many projects since then, and facilitated Indigenous cultural safety workshops together. And I think what really brings me to this work, as I do feel we have an enormous responsibility as healthcare professionals to ensure safety of all our clients, but in particularly to address the inequities and health outcomes of Indigenous patients. And so really for me, it is driven from a place of health equity and really ensuring that our patients do get the best care, and that as a responsibility as a healthcare professional to do that. It's a real honor to be invited to this webinar today, especially the first sort of fireside chat of the new college as an amalgamated college of all 9 professions. And so we're really interested to know who's here today. So Kathy's about to launch a poll. And so please let us know which profession you're joining from so we can get the breadth of the 9 professions that are joining us today. The poll only allowed us 5 options, so we did sort of amalgamate here in the spirit of amalgamation. So thanks, Kathy, for putting that up. And I'll turn it over to Kathy to kind of show us the results when they're ready.
Sure, so I'll just give everyone a moment to answer, and then I'll show you what everybody said.
Even I'm getting used to that, the acronyms that are on this page.
Okay. Ooh.
Great.
So, can you see that, Robin?
Yes, I can.
Okay, yeah. Good. So we can see 14% are either audiologists, hearing instrument practitioners, or speech language pathologists. 6% are dietitians. 22% are OTs or PTs. 8% are opticians or optometrists, and 50% are psychologists.
Okay, so thank you. It's nice to see the spread across the professions. And I'm just going to start out by giving a little bit of a background to the Indigenous Cultural Safety and Humility Standards. So some of you may know that the standard was actually drafted by the College of Nurses and Midwives of British Columbia and the College of Physicians and Surgeons of BC, and it was published by those 2 colleges in January of 2022. And it was informed by contributions from Indigenous people and guidance from Indigenous leaders during the consultation process. And then subsequent to that, our 7 legacy colleges worked together to adopt the standard for our own registrants in and around September of 2022, with permission from the Nurses College and the Nurses and Midwives College and the College of Physicians and Surgeons of BC to do so. And essentially the only change that was made when the 7 legacy colleges adopted the standard was to change it to reflect the name of our own professions. From the standard in the introduction, there's some content there that notes, Indigenous specific racism and discrimination negatively affect Indigenous clients' access to healthcare and their health outcomes. And these impacts include, but certainly aren't limited to, lower life expectancy, higher infant mortality, and the increased presence of chronic health conditions. And so the purpose of this standard is to help set clear expectations for how registrants are to provide culturally safe and anti-racist care for Indigenous clients. And you'll have noticed in the abstract for this webinar that Robin and Dr. Rebekah are going to frame their conversation using the 6 core concepts set out in the standard. And within these concepts, there are then principles to which healthcare professionals are held. And we hope today's conversation will help you become more familiar with the standard and how to apply it in your own practice. And I'm going to introduce each concept of the standard throughout the webinar, and then Robin and Rebekah are going to share some stories. But you will notice that the stories that are shared today will often span or be related to more than one single concept or principle in the standard. So with that, we'll start with the first core concept, which is self-reflective practice. It starts with me. So the concept is a recognition that cultural humility begins with a self-examination of values, assumptions, beliefs, and privileges, and consideration of how this may impact the therapeutic relationship with our Indigenous clients. Cultural humility promotes relationships based on respect, open dialogue, and shared decision-making. Robin, I'll turn it over to you.
Thanks, Susan. And yeah, I really do believe that, cultural safety does start, it is really achieved through cultural humility and being humble about our practice. And so it really does start, I think, with reflecting. And so as a healthcare practitioner, I think we really, while we may be reflective in general of our practice, it really behooves us to spend the time to reflect on our identity and who we are. So I think now I reflect really regularly on my identity as a white female in a position of power as a healthcare professional, and really how this impacts the relationship that I have with my patients. But I haven't always reflected on these things. And I think about the times when I have probably done something without knowing, and I have thought things were benign and safe, but I didn't really recognize my position and my identity and my power in how that perhaps made an incident really unsafe for a patient. So I think it really starts with understanding your own identity first, understanding the privilege that you have as a healthcare professional, and then that commitment to act upon that reflection to address power imbalances. And that to me is the sort of foundational piece of developing a relationship. I think of a time years ago when I worked in Prince Rupert, at the hospital in Prince Rupert, and I had a student with me at the time, which kind of makes me a little bit even more kind of challenged about this situation. And I remember asking a patient to just walk across the room so I could watch and assess their gait. And that's something I do as a physio all the time, is to ask patients just to walk across the room and back. And the patient took a few steps and then turned to me and said, "This feels like residential school." And I remember being alarmed at the time, but also not really sure how to handle the situation. And I sort of swept it aside and carried on. And I think I was probably more embarrassed than anything else, because I had a student next to me and I, didn't kind of know what to do with this situation. And I probably at the time didn't know the extent of to which residential schools were really harmful, and I was less aware of that sort of colonial violence of and really that what would have happened to that patient at the time. Now, if that were happened to me, and it likely will or has since then, I think I do really take the time to reflect, and I would absolutely take the time to debrief with the student kind of around those things. But I think I would use it as an opportunity to really reflect on my power and privilege in that particular incident, and really to think about, what can I learn from this situation? What can I learn from the patient? Yes, but more so from myself, and how perhaps the way I take for granted something that I might say that is part of my practice, that in fact might be quite harmful to a patient. And I think we'll talk a little bit more about that in the sort of later standards around kind of like trauma-informed practice. But I think for this one in particular, I really feel like in order to build that therapeutic alliance that we so often talk about, we first need to know ourselves, and that really comes from reflection, the biases that we have, the stereotypes that we may unknowingly kind of be attached to, and then really taking the time to think, to write, if that's what is a helpful reflective tool for me. I often just need to write out what I'm feeling and what I'm experiencing, and then really sit with it. Turn it to Rebekah for some thoughts on reflection.
Sure. I guess I'll touch a little bit too on just my experience in the past week. So the Canadian Medical Association apologized to Indigenous people 5 days ago, and I had the opportunity to be there during the day and for the ceremony. And I will say that the Canadian Medical Association spent a lot of time actually going through their historical records, reflecting on areas that they missed, areas of missed advocacy for Indigenous children in residential schools and Indigenous patients in Indigenous hospitals and Indian hospitals, where they, our power and privilege of a profession was not used for good. So that's one very concrete and large example of, a missed opportunity, but potential areas of improvement moving forward. From a personal perspective, it's been interesting as being an Indigenous physician, but also as a physician in our healthcare system, just realizing how patients access care. And even if I try and relate to people as an Indigenous person, I still have that power imbalance of being a physician to them. That can be hard to like mitigate that power imbalance. So one of the best examples that I can think of this is when I was actually still in my training, and I was working in a unit, and there was a mom that was really struggling with breastfeeding of her new baby. And it was like clear to nursing and healthcare providers that it was like a confidence issue, and probably a bit of depression as well happening at the same time. So I went to speak with her to see how I could give some support, but we had a hard time connecting. And then after reflecting a little bit, I think it was because she still saw me as someone who was like above her, I guess, because that's how she'd been treated, and felt like she'd been treated throughout her whole life in the healthcare system. And so one thing that I did in order to erase that power imbalance was get an elder to come with me to speak with her. And so we talked about her healthcare together, and then came up with a plan around breastfeeding. And so I think it's just important to think, like, even if you're in a position where you might be a BIPOC person, so Black, Indigenous, person of color, like just being a healthcare professional does put us in a position of privilege, and there's still work that we have to do as well. I like one of the sayings of one of my mentors who's an Indigenous physician colleague. She always says openly, like, we're all racist. Why don't we start there? We're all racist, every single one of us. We all have ways that we think that might be based on stereotypes and might be harmful to other people. And so if we start with that, we can then do the reflective exercises that Robin's mentioned, which is like thinking about how we're interacting with patients that might be harmful, and then we just move forward and improve the healthcare system. Yeah, that's all I have to say. I'll pass it back to Susan.
Susan, just one point that I might kind of add on to that, thank you, Rebekah, is that reflecting can be really painful. I think probably for some of you, when Rebekah said that, like, why don't we just start from the fact that we're all racist, that can be hurtful and really painful. And I think that that's one of the pieces that comes with reflective practice, is learning to be comfortable with uncomfortableness, with being, with acknowledging the pain associated with some of this. I know that for me, often when I have this conversation with students, I talk about needing to do the heavy lifting that I think as settlers, I feel I need to do. And I need to do that hard work of actually sort of recognizing that, yeah, perhaps at times I have kind of drifted into that sort of saviorism that as a white settler who chose to go into a healthcare profession and wanting to help others, there's a fine line between helping others and the colonial principle of doing good. And so what does it mean when I go into a remote First Nations community? That can be misinterpreted if I'm not really careful about how I'm approaching that. And so really thinking about that and doing that hard work around what does it actually mean for me, and what is my identity, and how does that come across, and how do those things that I say and really matters. So I just want to say that it's hard work. You know, we sort of think about reflective practice as often being, you know, something that, yeah, is part of what we do, is part of being a better clinician and recognizing our competencies or, you know, gaps in our knowledge, but it actually is hard.
Thanks for that, Robin. Just before I move on, Kathy is monitoring the questions in the background, so she might save some of them to the end, but I just want to check in after each concept to see if there's something that we should have the two of you speak to now. Kathy, any questions that you think we should speak to now?
No, thank you. Nothing's come in just yet.
Oh. So we'll move on to the second concept. And as I say, you will see some crossover between the concepts as the stories continue. So the second core concept is building knowledge through education. And as health professionals, we are expected to continually seek to improve our ability to provide culturally safe care for Indigenous clients. and that our learning about the historical and current impacts of colonialism on Indigenous peoples and how this may impact their healthcare experience will continue over time. Robin, I'll pass it back to you.
Thanks, Susan. So yeah, I think that I like the way that the standard is sort of set up with this sort of learn, understand before you act. And I think building knowledge through education is a really critical piece. And I think, again, you know, cultural humility is lifelong learning. I like the fact that we've moved away from the concept of cultural competence, because really there is no such thing as kind of being, knowing it all. I really feel like it is that long journey. And so I think to be an ally is actually to spend the time and make space for the kind of learning and the constant education that's sort of needed. I know I seize every opportunity to learn about historical and ongoing impacts of colonization, to learn about intergenerational trauma, to always be thinking and learning about cultural barriers to care. I think this often means we need to walk the extra mile. And so I often have kind of, you know, reached out and done things on my own time, at my own expense. Again, that piece around kind of doing that heavy lifting piece. There's lots and lots of training available and lots of different workshops. And I think you can just gain a lot from attending workshop seminars, opportunities to sort of meet with elders, reaching out to various resources and drinking endless cups of tea. So Rebekah and I have the fortune to, you know, work in a community that is accepting of the fact that we often bring students into community to learn to be culturally safe practitioners, and so there are many community members who are willing to sit and drink tea and tell us stories. But that does mean that we need to often at the end of the day go for a long walk or go berry picking with others so that we can have that opportunity to learn. And I think, but also balancing that with recognizing that it's not up to Indigenous people to teach us, that we also kind of need to recognize that it is an effort that we need to go and seek that out. So just recently on Friday, as an example, knowing that I'm going to go into community in a couple of weeks, I went to the Indigenous liaison officer at the hospital. I don't work at the hospital here in Prince George, but I went to there to meet with them to say, hello, I think we have a patient who's going to be discharged to the community, and I'd just like an opportunity to kind of meet with you and chat with you and put a face to a name before I'm going to see this patient when I go to community. So it is about building kind of those opportunities to learn and those opportunities to just continue that lifelong learning process. Rebekah, over to you.
Yeah, I really like a few of the points that you touched on. And so I'm actually going to start with the one that you mentioned, that it's not up to Indigenous people to do all of the teaching. So I can't speak for other professions, but I know in our Indigenous physician community, we get called upon to provide advice in a number of settings, sit on different committees, review manuscripts, and all of it is good, and you know, we want to help, but it also takes a toll on our professional and personal lives. We're putting in the effort, like helping our colleagues to do that. And so I appreciate Robin's comment that we need help to do all of this heavy lifting, which is changing the healthcare system. And we really do need a partnership with our non-Indigenous colleagues in order to do that. And so that's one reason why we are doing the webinar this way with myself and Robin, is to demonstrate that we need to do this in partnership and together, because we don't want to burn out our Indigenous healthcare professionals. I mean, just reflecting on the TRC report, which came out within the last decade, I mean, they had to actually say, like, we need Indigenous healthcare providers in all healthcare professions. Like, that actually had to be written down because there was a paucity of healthcare professionals across the board. And so, yeah, just taking care of each other. And two, I like the idea too of getting out in the community and learning from them. I know just in general in Indigenous communities, like we have to listen to our elders and what they have to say. And the way that you learn from them is by spending time with them. So it's exactly what Robin says is, it might be tea at the end of the day, it might be visiting them for breakfast in the morning. We've gone to play volleyball with the communities in the evenings, helped to pick medicine for elders who are sick. And it helps both of us, because I understand when patients tell me, you know, I'm going to go pick some Devil's Club for my husband who's not well. What that actually means, it means like trekking deep into a bush. And I didn't know, but Devil's Club is not a plant that you pick. It's got some like girth to it. It's like has bark, and it's difficult to prepare for tea. So I learn about that process, and they learn about Western medicine as well. So the goal is to combine the two in the end. But yeah, I think spending time is important. I know a lot of people too ask, you know, they might be a physician and say like Dawson's Creek or Kamloops, you know, where do I start? I don't even know the Indigenous community where I live. And so one place to start might be the local friendship center. Like you can just go check out the webpage and see what events might come up. So big days during the year are Indigenous Peoples Day in June. September 30th is also coming up as well, which is a week from today. So I expect that there'll be some events close to where you live as well. And during the summer, different communities have like powwows and stuff. Like there's like a powwow trail in BC for sure. So just seeing Indigenous people when they're well too. I know for me, it's so different seeing someone comes in and they look terrible, like, oh no, they have diabetes and their knee hurts, and their mom just had a stroke last week, and they might look terrible. And then, so I'll see them in the office, and then we'll go to a community gathering where they're there, they're drumming, they're singing, they're leading the community. I'm like, oh yeah, like this person is like, you know, a force to be reckoned with in their day-to-day life. Like, how can I get them to that next level? So it just like helps us remember to, just from like a personal perspective, that these people are well. We stop looking at them from a deficits perspective, which unfortunately society has done to Indigenous people for a few generations at the very least in Canada. So it's a good way to just start changing that in your day-to-day life and day-to-day practice. I think those are all my reflections. I'll pass it back to Susan.
Sure. And Kathy, just checking in one more time. Any questions, or should we carry on?
There is one that I think would be good to share. This is a question for Robin. It goes back to your description of when you had a student and assessing gait down the hallway. And the question is, if you were to be in the same situation again now, what would you do differently?
Thanks, and apologies if you can hear the drill that's just started behind me. I would actually stop and pause the entire assessment and actually, you know, approach the patient, who I hope I had already built some, you know, trust and conversation with, to be able to say, look, I recognize I just said something that could have been very harmful, and I apologize for that. I apologize for not recognizing that. I'd like to give you an opportunity to teach me, or an opportunity for me to learn from this situation. Is there anything you'd like to kind of share with me? I would give them, we'll talk probably about this a bit more around the kind of trauma-informed practice and pieces, but I think I'd also give them really choice. Do you want to continue with this session today? And give them, again, it's about that empowerment piece of and that self-determination piece around giving the patient an opportunity to make the next move, to decide whether to carry on with the treatment, to decide what I needed to learn from that particular situation. And I would really make it sort of bring it out into the open. I think that's the big thing that reflection has really taught me, where I always sort of slip something under the cover. Ooh, maybe I shouldn't have said that. Ooh, maybe that was harmful. And then now I bring it forward and I recognize it, and I will, yeah, bring it to the forefront, and then have that deep conversation with the student afterwards about it. Thanks for the question.
Can you expand on that a little bit? Like, I'm wondering if the person with the question is wondering, how would you have asked if you wanted to assess that client's gait, knowing what you know now? What kind of, like, would the prompt be different? What, like, what would you do differently in terms of conversation with the patient when you go to assess their gait?
Yeah, I think, thanks, Susan. I think this really speaks to what is culturally safe care, right? You know, and I think I still assess gait, absolutely. It's a critical part of what we do as physios. I just might have, I might do things slightly different depending on the situation, or I might have just said it exactly the same way. But I think it depends. I think sometimes I often, very often, if I'm working with patients who might not be as familiar with physio and what some of the sort of things that we do as physios are, how we put our hands on people, or the way we look at patients, or things like that, I often kind of sort of say, you know, in order to better understand what might be going on with your knee, it's really helpful for me to kind of look at the way you walk. And so I'm wondering if it would be okay if you walked across the room. If you're not comfortable doing that, would you, could we assess the way your knee is moving? So often I'll actually couch questions or assessment pieces with a lot more context about what our intention pieces are, just so that, again, and it may still, for the patient, feel like I'm being asked to walk across the room and being watched when I'm doing something, which was reminiscent of a something that might have occurred in the past in really uncomfortable and harmful situations. So it might still be, to use the word trigger, it might still cause that trigger, but at the same time, perhaps the way in which I have better framed it, or maybe not. But again, the piece would be how I react, and then whether the patient feels like the practitioner is actually understanding and caring and creating a culturally safe environment. So I hope that provides the kind of breadth of answers. There's no one right answer, I guess, but it's, yeah, hopefully that's helpful.
Rebekah, did you want to add anything?
Yeah, I just wanted to share something that another one of my Indigenous physicians colleagues states, and it works well in primary care, but I think it helps when we think about anywhere else. They say the relationship is the intervention. So essentially, like, without that trust being present, it's hard to get anything else done, especially when somebody's, remembering the trauma that they experienced in residential school. I just know from, like, personal experience too, working with Indigenous patients, it's like sometimes it might take a long time to get things done. We all have, like, our check boxes of things that we need to do to be a good healthcare provider, and we, like, do our best to get those done. But if someone doesn't trust you, they're never going to follow through with your treatment plan, like, ever. You can have the best treatment plan in the world, it's perfectly written, but they may never follow through with it if they had a bad experience with you. And so I think that's why it's important that what Robin was saying, just to, like, stop, take a measure of what's happened and, like, acknowledge where they're at, and then you can move forward. And that's something that they'll remember, not just for that interaction, but for a lot of other interactions with the healthcare system moving forward.
Thank you. So we'll move on. The next core concept is anti-racist practice, or taking action. So taking action means taking active steps to identify, address, prevent, and eliminate Indigenous specific racism. For example, one of the principles for this core concept is taking appropriate action when we observe others acting in a racist or discriminatory manner towards Indigenous peoples by supporting clients, colleagues, and others who experience and/or report acts of racism. I'm not sure, Robin or Rebecca, who's speaking first.
Rebecca, do you want to go first? It doesn't much mind.
Sure, yeah, I can go first. So I just wanted to take a step back too and just remember why we're doing this webinar, why we're talking about it. So essentially that the healthcare system as a whole has done a tremendous amount of harm to Indigenous people. And so examples that I can think of in medicine are Indian hospitals, which were essentially second-class hospitals that were understaffed, didn't have the amount of resources, didn't have the supplies that were needed for Indigenous patients. And then we're also a source of a lot of harm too. So there's stories of different medical experiments being done on Indigenous people in these hospitals, and also forced sterilization. So I'm not sure if people are aware, but there were a few provinces in Canada that actually had eugenics policies. So they were policies and full of recommendations on who should be sterilized. And one of the people groups that were targeted were Indigenous people for sterilization, because there's a history of the government saying that we were not fit parents. So that's just a small snippet of what's happened. And so when we think back about the patient that Robin mentioned who was walking down the hall and was like, this reminds you of residential school. Well, there's a lot of other history there as well that's brought into that one particular patient encounter. And another thing that we also have to remember is just the lack of healthcare and lack of healthcare knowledge because of that for Indigenous patients. I have an Indigenous physician colleague that grew up in a rural community, and she did not see a physician until she was 16 years old. So of course she was born in a hospital and then discharged from that, but she never saw a physician until she was 16. So she did see a nurse, so that was definitely some help, and she was glad that person was a resource in their community. But you can imagine if that is her experience, that she definitely never saw an eye doctor, she definitely never saw a physiotherapist or an occupational therapist, or any other allied care providers. And even this day, I have lots of children in communities that certainly need a lot of speech language support and OT support, and that is a very difficult resource to get there, even for children who need a lot of support. It's a difficult resource to get there. And Robin does tremendous amount of work with our patients in Carrier-Sicani territory, going into the community and seeing them and spending time with them and doing it over a long period of time so people can trust her. But you can, how many other physiotherapists you know or have met that do that kind of work? So yeah, there's just essentially a lot, because of that lack of resources in community, people also need a lot of extra help when it comes to healthcare knowledge. What does a physiotherapist do? They might not know. They've never seen one. What does an eye doctor do? They might not know, them, or no one in their family has never seen one. So I think one thing that I would recommend for everyone to do, and I know it's something that Robin's brought up, is just telling people what their role in the healthcare system is and how they can help them. Is a good place to start. One other thought that I had is I also want to just emphasize when Robin talked about taking time, sometimes it's needed. And I know it's difficult, especially for those who are in private practice and need to see volume in order to make overhead and make the clinic managers happy and stuff like that. But sometimes it just takes a bit of extra time to orient someone and make them feel comfortable in the healthcare setting. Unfortunately, as I mentioned before, our healthcare system was not built with Indigenous people in mind. And so the reason that we have to take time is not because Indigenous people aren't good enough, is because we're helping to undo the generations of harm that we're doing before. We're helping to deal with the trauma that they've experienced before. And sometimes it can feel like a lot to take on in one visit. I know for myself, I like feel fortunate in family medicine. I get to see people one time. If they like me, they'll come back again. So I get to see them over a period of time, which is nice, and work with them. And I think that really helps. And I do my best as a family physician, like helping them to encourage to see like all the other allied care providers as well that might be important in their care. And I'll pass it to Robin.
Yeah, thanks, Rebecca. So much there. And I think, you know, pieces that stand out for me is, I think when we talk about sort of anti-racist practice, it needs to kind of happen at all levels, right? So it's at that individual level, like what can we do in our practice, in our way? And then there's the systemic piece, right? So to me, it's really critical that as health professionals, we act at both those levels, that we kind of instill it in our own practice. So what we've talked about, some of the ways that can kind of look like in terms of what our interactions are with patients and how we set up our own practice. But then I think the systemic pieces are really, really critical. And those are the ones I think it's really taken me years to kind of like, where are all the places that I can make change at the system level? You know, everything from calling it out when I see it happen. So, you know, when I see racism happening, or when I hear something, being actually willing to speak up and say that this is not okay. And then, you know, take that bit of that responsibility and say, if it's okay with you, can I use my privilege to stand up for justice? And like, what could that look like from my power and my privileged position to make a change? It's also about acknowledging the injustices of the system to the patients. I've found over the years that that's really important to do. So when patients tell me a story with their encounter with a healthcare system that was really unjust, or that a stereotype was applied to them, I acknowledge that that's wrong, and I will come right out and say, absolutely, that was wrong. And I let them know that when they say, a classic one, perhaps this month or so ago, with a patient who was clearly being denied treatment in the emergency room, and had an ongoing chronic condition that really warranted needing to be admitted to the hospital and get specialist care. And, you know, the patient's response was, if I was white, this would not be happening to me. And I actually said to the patient, you're absolutely right. You know, the barriers that are in place that prevent this patient from receiving the care they really ought to have are so many and numerous. He was absolutely right that care would have looked very different if that patient had been white. And so I think it's really critical that we call those things out and we say them when they are the case. And then we do our own work kind of at the individual level as well. As Rebecca kind of noted, I think one of the other system pieces for me, sure, we're not there yet in terms of having, you know, physio being covered under non-insured health benefits for Indigenous people. So keeping on advocating, the amount of time that I've spent advocating for funding for wheelchairs and things like that, where really we do have to put in that extra time and effort to kind of raise our voices about some of those things and recognize that, yeah, the healthcare system is this hodgepodge of, you know, jurisdictional things for Indigenous people, and that's wrong. That just, it's not. So yeah, I think a short way to say we just have responsibility at the systems level and in the individual level when it comes to anti-racist practice.
Thanks, Robin. I think that's helpful to sort of separate it into those two levels. I think, Kathy, are there any questions here before we move into the next core concept?
There's one around resources that I flagged for addressing later, but I know we're going to speak to that towards the end, so I'll just pause that for now, and we can come back to it.
Okay, thanks. And the next principle really builds from the anti-racist practice taking action concept. So the fourth core concept is creating safe healthcare experiences. So as healthcare professionals, we're expected to facilitate safe healthcare experiences where Indigenous clients' physical, mental, emotional, spiritual, and cultural needs can be met. As an example, one of the principles in the standard is that health professionals must facilitate the involvement of the client's family and others. So for example, community and elders, Indigenous cultural navigators, and interpreters as needed and requested. And Rebecca's already given an example of her own where an elder assisted with in the practice scenario. So Robin, I'll turn that over to you.
Sure, thanks, Susan. I think you know, creating safe healthcare experiences is really about that self-determination piece in particular, about really having the patient be an equal decision maker in our care plan. We talk a lot about in physio, and certainly with our students, about, you know, patient-centered practice and client-centered practice. But I think this is slightly different in many ways, in that we really are addressing the power imbalances and kind of applying that social justice lens in order to kind of create safety healthcare spaces. And I think, you know, everything from the fact that, as Rebecca said, not everyone knows what a physiotherapist is and does. And so every interaction is about really ensuring that the patient does have a good understanding of kind of what physio is. And then just not just asking for informed consent, but really extending that on to really giving the patient choice around what their involvement is in the encounter that you have. You know, I think I just recently had a wonderful student with me along in a clinical placement who did this extremely well in really being very open with the patient about what the student was going to do, what form of the assessment was going to look like, and then gave the patient choice, not just yes or no answers, but really, we're going to do this exercise, and the intent of the exercise is this, and we can do it in standing, or we can do it in sitting, or we could do it lying down. Which is be most comfortable for you? Giving the patient real choice over and autonomy kind of around the healthcare encounter is such an important element for me of creating that safe healthcare. And that's part of relational care, I think, which is the next one, Susan. So I'm probably kind of adapting a little bit into that, but it really is around self-determination and empowerment, I think, to kind of create those safe spaces. We'll probably talk about trauma a little bit later, but collaboration and self-determination and letting the patient kind of be the guide, and I think is such an important part of this. Yeah. Rebecca, thoughts?
Yeah, I think there's so many things that we can do in order to deliver safe healthcare. I just think about one of the settings that I work in at Luma Medical Center. So it's an Indigenous clinic. And when you walk through the doors, you're greeted by you're first greeted by totem poles on the outside. When you walk through the doors, you'll see a ton of Indigenous artwork. You might meet an Indigenous elder. You'll definitely smell some Indigenous medicines burning in our healing room. I know not every clinic is going to have the ability to do all of that, but doing some things like having local Indigenous artwork hanging in the office can be a very easy and great place to start. Number one, it helps you know what the artwork is in your community, so you'll get to do some learning. Number two, the patient will feel more comfortable. I know when I went to see my dentist, and he actually travels up north himself too, to visit some Indigenous communities. But I always get excited when I go and see the mask that he has throughout the office and other Indigenous artwork, and I just feel more at home. One other thing that's important in that we're still trying to do in medicine is incorporate Indigenous ways of knowing and Indigenous medicine into the healthcare encounter. So it's an important thing to consider, because if we go back to the Truth and Reconciliation recommendations, so the TRC report that was published, one of the recommendations is that Indigenous practices should be acknowledged in healthcare settings. So it's something that should be done. I know, like, I'll give you like a misstep that happened with me when I was helping a patient who had diabetes. So in medicine, we do a blood test called hemoglobin A1C, and we measure that every 3 months, and it gives us an indication of how well the blood sugar might be controlled for a patient. And so this particular patient came in, and her A1C was way too high. And so talking to her, like, we went through like all of my diabetes checklists. It's like, okay, well, we'll talk about medication, and we'll talk about exercise, and we'll talk about diet. And then, like, I'm definitely, a great doctor, again, great management plan. And then at the end, she's like, I'm not taking your medicines. Like, I just refuse to take your medicines. I'm like, okay, I missed the boat here. What's happening? Anyways, she went on to tell me that there's Indian medicines that she wanted to try, and that I wish I asked her about when we first started. But essentially, there's medicines that they use in this particular area, and so in order to get them, she has to go with a friend. They have to go hike deep into the bush, and so it's going to take her all day, and then harvest it and bring it back. And then, as part of the way that they're taught to manage their medicines, she also has to share it with other people. So on recollection, she actually would have met some of my checkbox items. So exercise, hiking all day in the bush, that's excellent. She was going with a friend, and we all know anyone managing a chronic illness needs social support. So that's another checkbox item. And then sharing with the community is also part of her healing as well. And I think I just was reflecting, like, if I asked her how she was managing it before I came at her with like what needed to be done to fix her problem, I think we probably would have gotten a bit further during that interview. But I think it's a wonderful opportunity to interlink both Indigenous and Western medicine, because going forward, I always ask people like what they're doing to manage their diabetes, and if they are managing it with traditional medicines, like, that is something I always encourage. Again, because it has so many other benefits other than just taking the medicine itself. It's a different, like, Indigenous medicines are usually different than going to the pharmacy and picking it up like we're used to. Like, if I were to prescribe something like metformin, so I think incorporating that into any way that you can. And that also helps too with, like, I know we have like a large psychologist contingent here too. That also helps with mental health as well, because there's different ways of healing that are traditional, different ceremonies that people might do for their healing. And again, I think it can fit in well with our Western model of trading, in that a person's going to go to a ceremony, they're going to be surrounded by people. Well, that's something that we're always trying to encourage when someone's struggling with mental health. They're getting connected into their community. They're learning more about like who they are and where they come from. Like, these are all things that are certainly going to help them in the long run. So I think as best we can, encouraging people and being aware of what they're already doing, essentially. And then another just story that I can think of is, I know there's a First Nations gynecologic oncologist, so someone who's obviously very busy, has an important schedule, needs to get everything done, but he's mentioned that whenever he has Indigenous patients that are traveling to his office, he is always very lenient with the time, just knowing that it's a huge barrier for them to get to the appointment. He's very lenient about like when they might be able to just make it into the office. Like during, like, for those, Robin and I travel down logging roads in order to get to the Indigenous communities that we work. Depending on the time of the year, sometimes those roads are awful and it can take a long time to get to the community, it can take a long time to get out of the community. So just being aware of that as a healthcare provider. Something else that he also says that he never does is charge no-show fees to those patients, because that can be a barrier for them ever accessing care again. And, you know, people might think that's controversial because, you know, again, overhead needs to get paid, bills need to get paid, clinic managers and whoever owns the clinic needs to get paid. I understand that, but at the same time, like, I think we have to just like take a step back and think about what no-show fees actually do for these patients who already have a ton of barriers just to make it to appointments. It might not be like meeting, like the goal I understand is for people to make it to their appointments and commit to the appointments, but it may not be meeting that goal. No-show fees probably are not meeting that goal, especially for Indigenous patients.
Thanks, Rebekah and Robin. Kathy, any questions to bring forward before we move on?
There are several really good questions, but they're going to be challenging to answer. And so I'm hesitating a bit bringing them forward in this context, but I'm going to do it anyway. And I'm going to trust that our two speakers are keen to jump in and try and put some context into these answers. So the first one is, I have my own medical trauma from being denied care for my daughter many, many times, and she now has lifelong nerve damage due to the delay in care. Is it important to help clients differentiate between racism and just poor healthcare due to huge caseloads and practitioner burnout? Is it helpful to let Indigenous clients know that long wait times and denial of care can happen to anyone? Oh, I see from your faces, this is big.
Rebekah, do you want to start?
Yeah, like I can certainly appreciate and understand, like even working in the hospital today, like all of the shortfalls that our healthcare system has, despite a lot of people like doing their best for everyone, for the general population. It's like we can acknowledge that and be aware that the medical system also purposely harmed Indigenous people. It wasn't an oversight. It wasn't an accident. Women were purposely sterilized. Little kids in residential schools were purposely starved for medical experiments. Indigenous people had, you know, surgeries done to them which were experimental on purpose, and this was not done to the rest of the population in Canada. So it's like, yes, I think we can acknowledge that and also be aware that things that were done to Indigenous people were a result of racism and definitely on purpose. And what we're trying to undo today is a lot of those purposeful harms.
I echo. I don't have anything else to add. I think that's really important.
All right, the next really big one. I have frequently noticed in psych assessment reports for Indigenous peoples the traumatic impact of being within the WorkSafe-BC system, which is another whole system, different than similar yet to healthcare, that they have reported to me, as it can be a significant traumatic stressor in its own right. But this seems to be minimized or ignored by the organization, which I assume is the WorkSafe-BC organization. Any suggestions for how to further navigate and ameliorate this apparent disconnect? I think it's a systems-based question, but I'm curious to hear what approach you might suggest.
These are tough questions, I'll admit. I think that there's always a role for us to advocate and for us to educate. And so I do, you know, feel as if, you know, as a health provider and working within that system, you have a role to kind of stand up for the patient and to do that additional education of, you know, the caseworkers, et cetera, about your patient and then to advocate. So I do feel as if Yes, these are additional systemic things that are challenging, but there's always a role that we can play, I feel. Rebekah, any thoughts?
Yeah, this probably applies to a lot of different systems, but I feel like in general, like what Robin mentioned is I feel like we do have the opportunity to advocate for patients. I know for our role, sometimes that looks like writing medical letters. It doesn't have to be like a huge report necessarily, but just updates to WorkSafe BC, maybe more so than what you might do before helps. And I would just say, I feel like every organization probably needs to do a bit of a deep dive into how their practices can start working towards anti-racism.
Can I maybe push a little harder on that question because of something that came in as you were speaking? Just to piggyback on this, when someone is denied care at emergency, how do you know it's due to racism?
I can just give you an example of that one of my family members went through, and maybe this can help. So it's like a one-dimensional question, but it's actually not a one-dimensional question. I think it's a multi-dimensional question. I have cousins that live in a remote Indigenous community up north, and they had a daughter that was born with a lot of disabilities. So she was ambulated with a wheelchair. She had a seizure disorder and had multiple visits to Children's Hospital over the course of her life for different times in her life when she needed support. Saying that, she was like a well-loved member of her community. So she was at like vacation Bible school every summer. So Sunday school every Sunday, went to school every single day, and like participated in all of the activities that were available to her in her community. And she was well cared for. Despite her complex needs, she was well cared for in a very low resource setting because her parents were so diligent. And so where they lived was an hour boat ride from the nearest emergency department. So one day, a few years ago, they felt like she was not herself. And because of all her healthcare needs, they brought her to the hospital saying, we're worried about her. We think something's wrong. Like, can you look her over? And so they brought her there. Nope, everything's fine. She was discharged home. And so they took the ferry, not the ferry ride, they actually had their own private boat. They took their private boat back home. Well, overnight she decompensated and then was struggling to breathe. And so a helicopter then had to come get her from her community, fly her back to that small hospital where she was actually now too sick to stay. And so she had to be sent down to Children's Hospital. And so she actually died from that illness about a week and a half later. And I can remember going to visit my family members, my cousins, while she was admitted to the ICU. And they told me, and so these were two working people, like they fish all the time. One of them helps out in the school. They showed me her bag, which was like so organized. I don't know if, like, for those of you who've had small children and know what diaper bags are like, it's not always super organized. Well, her medical needs were so complex that if you looked, it was like so well organized, all of the different things that she might have needed through the day. Anyways, he hands this to me and was like, I think we take good care of her. Like, she's dying because we're Indigenous. And so, well, that individual doctor might not have like purposely done anything that was discriminatory to my family. Like, just take a step back and think again, that lack of health care that's in a lot of Indigenous communities is a result of the Canadian government really not setting up the healthcare system that allowed equitable access to care in those Indigenous communities. And there was also a lack of acknowledgement from the hospital's side that this family with a complex care need patient who is also from a remote community, like she probably needed to be admitted to hospital overnight for observation, just based on the fact that these two parents who were very reasonable and took very good care of him just had a concern that she might not be well. And I think it was too that their their parental intuition on how their daughter was dismissed completely in that situation. And if we look back at the In Plain Sight report, which was published a few years ago as a result of concerns about racist practices in the emergency department, one of the most jarring things you can read in it is the comments that patients had about how they felt that their experiences were in the healthcare system. And one thing that resonated was that Indigenous parents felt like the emergency department and the healthcare system was telling them that they were not fit parents, which is, again, a theme that's echoed for a long time when you look back at residential schools, the 60s scoop, forced and coerced sterilization, we're not fit parents. And so, that one emergency doctor and nurse that they saw might not have been purposely racist. It's that lack of sort of understanding about the system as whole, which was a racist experience for my family.
Thanks for sharing that heartbreaking story, Rebekah. I think you've said it really well, and you've made it. I think I often think about how the intersectionality of so many of these determinants of health come together for Indigenous people. And so when, I think I've come to sort of accept the term structural violence as kind of really recognizing how, because we can change these structures do not have to be this way. And so it is in fact what those barriers are, and that we put those barriers are there. They're put there. They don't have to be there, and yet they result in the care that ends up being so harmful for patients. So I think you started that answer really well, Rebekah, to say this might just seem like a single kind of dimensional question by saying, how can we say this person was denied, or the care that they received in emergency was racist? I think we really need to examine that question and examine that assumption piece to say and recognize those multiple layers and intersections of determinants of health. And that's what makes it that many people are denied the care that they actually need.
Yeah.
Thank you. Kathy, any other questions before we move on?
Shifting gears a little bit, the question is, it is paramount to take into consideration Indigenous health practices. Rebekah has alluded to that a couple times now. How does this affect professional liabilities?
Susan, do you want me to take that one? Because you and I have had that conversation kind of in the practice advisory kind of role in a college. And I think that from my perspective, I think Rebekah told the story well, in that I'll often ask patients about traditional practices that they're engaged in, or perhaps, as Rebekah talked about, going and collecting medicines, because it's an opportunity to learn. And I think part of delivering culturally safe care is to have humility. And to have humility, you need to ask questions and you need to learn. And so traditional practices and medicines are part of that learning. And although as a physiotherapist, I would not deliver those practices, nor it's not my place as a health professional, and it's not my place as a settler to do that, it doesn't stop me from learning about them and better understanding how, in the spirit of two-wide seeing, where we can have the best of all worlds to kind of deliver what we, from the Western medicine perspective, thinks that the patient is most appropriate from the patient, to blend that and better understand with what the patient might be participating in that they see as health and wellness that is best for them. So I think, you know, and I Susan, perhaps I've described it better in other situations when you and I've had this conversation, but I think it's really important to kind of recognize our scope and recognize what we're doing, not only as professionals, but also as individuals, kind of, and again, that identity and where we come from and who we are coming to that healthcare encounter, but then also kind of recognizing how we can be humble and be learning within that situation with the patient to better learn together and finding out together.
Yeah. I don't know if Rebecca wants to add anything, or are you?
Yeah, no, I was just gonna say, I think I like Robin's idea of learning about it, because people are likely doing it whether or not they tell you. So it's like, it's just nice to know what's happening. And there's also just like, I was given another story. So, and I was helping an elder in one of our communities who has a lot of health issues. And so his code status was that he wouldn't want CPR to be intubated if he were to get sick. Well, when I was in community one time, he did get very sick. And so I had to have like a huge discussion with his family. And I felt like half the community turned out. There was 40 people in the house, and we had to like have a goals of care discussion about this elder, because it's so important to the community, about what they wanted to do or what they felt like he would want to do. And so they decided that he was going to stay home in his house and just see how things went overnight. Saying that, his wife, who is 84, and their family members went out and got some traditional medicines that evening and gave it to him over the night. And so he looked so sick the night before. Again, I was worried that he was actually going to die. And the next morning I went to see him, he was sitting up eating porridge, watching TV. And so, you know, everyone was like, well, it was our prayers and it was our traditional medicine. Thank you so much for coming around, doctor, but we'll take it from here. So thank you. So yeah, like people will be engaging in these practices. It's good to know. It's good to know like what else is helping them with their care. And then I'm sure it's not just limited to Indigenous people. I know there's a lot of other cultures across the world that also engage in other medicines that aren't the traditional Western medicines as well.
Thanks. Kathy, a few more questions or?
There are, but I think maybe we should finish the last two concepts of the standard and then see how much time we have left at the end, because we do want to talk about resources for sure at the end.
Yeah. Okay, sounds good. So the next core concept is person-led care, and that's really about relational care. It's already been touched on quite a bit, but for this concept, health professionals are expected to work collaboratively with Indigenous clients to meet the client's health and wellness goals. As an example, one of the principles is to engage with clients and their identified supports to identify, understand, and address the client's health and wellness goals.
Thanks, Susan. I might just kind of start with that from the perspective of physios who are often so goal-oriented. And I think that's been a big lesson and learning for me in working in community and really recognizing that, in fact, that might be a very Western concept to talk about client-centered goals. And I think, you know, I've recognized it really often because we teach our students to set goals with patients. And I often hear when I'm, you know, with a student and a student is asking an Indigenous patient about their goals, and they sort of get this really strange look, like, I don't quite know what you're talking about. And I think that what the important lesson for me around this is really to better understand what does health and wellness look like for our patients. And I think we need to often start the conversation with that and really take the cues from a patient around some of this, because the concept of a goal can be very, very foreign. And so, yes, in the context of kind of relational care, I think we've talked a lot about some of the pieces around what kind of builds therapeutic alliance and building that trust with the patient and better understanding what's important to the patient and how, you know, that really then guides our assessment and our treatment. And from my experience, it certainly is really better understanding the context for the patient and about whether exercise is, as we might know it from the Western perspective, is actually relevant and important, or to be more functional and to talk about some of the things that Rebekah alluded to about, you know, collecting medicines or, you know, going hunting and what does that look like, and perhaps some things that, again, would be actually much more effective and much more in line with what the patient is looking at. So sometimes it's just examining kind of our language and our you know, Western approaches to what healthcare looks like, and instead learning about what health and wellness means to the patient. Rebekah, thoughts?
Yeah, no, I definitely agree with everything you said. I guess just the one thing to circle back to is sometimes elders or Aboriginal wellness liaisons I know that are available in hospitals can be really helpful in just helping with that patient-centered care, like coming to visit people, talking about where they're from, and just being able to provide that extra bit of support can really help. I know that might not be available to people who are in private practices, but sometimes it's like you can even encourage people to like seek out that support in their local community as well. And like hopefully, ideally down the road, there'll be much more Indigenous, like interdisciplinary clinics like the one that I get to work at, which I think patients find really helpful.
Goes back to something you said earlier, Rebekah, too, which is that without that relationship and trust, you're not going anywhere. So that notion of the person-led and relational care is just so important foundationally to the relationship. Kathy, any questions connected to this concept, or we can move on to the last one?
Let's move on to the last one and come back depending on time.
Okay. So the sixth core concept in the standard is strengths-based and trauma-informed practice. That's really about looking below the surface. So health professionals are expected to have knowledge about different types of trauma and their impact on Indigenous clients, including how intergenerational and historical trauma affects many Indigenous peoples during healthcare experiences. We focus on the resilience and strength that clients bring to the healthcare encounter.
I could start here, and then I think for me this really ties together so many of the concepts that we've talked about so far, and strength-based for me really is about honoring identity and belonging, and I think we know Indigenous ways of kind of knowing around health where those two things are really important, right? So belonging to community, for many folks, language and culture as being kind of anchors to their health and well-being. And so I think when we talk about what does this look like, I think it is very much around meeting patients where they're at and having them be a big part of sort of determining what health looks like for them. And so that's much more about, like, I'm interested in learning more about you and your culture, and I'm interested in learning much more about kind of what makes you healthy and well, and really I think that for me is a big part of that strengths-based approach. And that I think is a really important kind of first critical step for us as physios. We tend to be so focused on the physical elements of health, and yet you know, really this is all about holistic medicine, which really is about better understanding the emotional, spiritual, and mental aspects of health. And so while I don't pretend in any way to be experts in that area at all, it's so important for me as a physio to really approach health from those bigger perspectives. and not just focus on the physical elements. I think that's a big part of learning for me in the past, and continuing learning for me is about how to do that well, and how to actually convey to patients around that holistic element of that. And in part, that's driven because I think we are learning more and more about trauma and how trauma is, in fact, affects the nervous system and is held physically within patients. And so I have spent lots of time recently in learning about the effects of trauma, of intergenerational trauma, of how emotions and the spirit is affected by trauma, and what happens when it's internalized. And I think I'm now much more comfortable, instead of avoiding that and doing things that can kind of might be triggering, actually recognizing it in the patients. And in part because I think, you know, to Rebecca's comment earlier, if you don't have a relationship with a patient, there is no treatment. And also, treatment is not effective if the patient is not in what the language is commonly kind of used around that sort of window of tolerance. If the patient's actually able to participate in physio, they're not, doesn't matter what my treatment's going to be, it's not going to be helpful. And so I do encourage people to learn as much as they can about what trauma-informed practice is and how trauma manifests itself in the nervous system, and better be able to kind of be comfortable with the fact that many of our patients have experienced trauma, have experienced adverse childhood experiences that will be stored and that we will have to kind of recognize, and we need to work with that in order to be able to be effective in our roles. We could do a whole session on trauma-informed practice, but I think I might just kind of start there, give Rebecca a chance, and I'll have you collect my thoughts.
Yeah, I agree, there's a lot there we can discuss. I know, like when I meet with other Indigenous physician colleagues and we talk about some of the illnesses that might present as a result of trauma, that become like medical diagnoses down the road. It's huge. Like we can even talk about like diabetes, you know, that can be a result of trauma. Why? Because of food systems and the way that people used to collect food and distribute it within their communities was disrupted because of colonization. There's a lack of access to like fresh fruit and vegetables in a lot of these smaller communities. That can influence diabetes. You know, people are not as able to go out do their traditional hunting and the way things were done before, so there might be less physical activity. That can result in diabetes. So yeah, there's lots of layers, and that's just one example, but there's like a number of other chronic pain issues, mental health diagnoses are also a result of trauma. I feel like one simple example that I do when I see someone's flustered and they're coming into clinic and they might be like late, it's just like, you made it. Awesome. Like, you made it. Just getting here was hard. And I feel like that just like de-escalates. They're like, okay, great. You know, my doctor's not mad at me. I can actually tell them what's wrong and what's going on today. So just being aware of things like that. I know my particular practice, I love to see a lot of like young moms, single moms, and moms who have struggled with substances, and they're trekking in there with their kids, and it's, you know, on the bus coming from across town. So just acknowledging that, I feel like pays a lot of dividends. And then I think also just circling back to my other point of being aware of all the trauma that I mentioned before, and I think everyone's at different knowledge levels. Like, you may just be learning about harms to Indigenous people in the healthcare system, or like the harms of colonization. I think it's important to know about all of that and see, but also is important to see Indigenous people while they're well in different community settings. So you get both, like seeing what's possible for people when they have appropriate supports in place.
Thank you. I'm just noting that it's about 25 after the hour, and I think from what Kathy said, it sounds like we've got lots of questions. So I'll turn it back to Kathy to see if we have time for a couple more questions.
So there's one about this. Are professionals in your vicinity or your context including different ways of seeing and doing in client-led care? And if so, do you feel supported by the leadership in moving away from systemic Indigenous racism? How much support are you getting from the institutions you work with?
Well, it's a good question. I think I think I'm fortunate in that increasingly I feel as if organizations are recognizing the importance of this. And so, you know, Rebecca and I both are engaged in an Indigenous-led organization. And so we do have lots of support for this in our primary care work. I think in some of certainly when I'm teaching students and students are out on clinical placements and we're talking about these kinds of concepts, I think there's increasing awareness of some of the important pieces of, you know, taking the time or being able to engage in these conversations. So I do feel like we're moving in that direction. Rebecca, you work across a bunch of different institutions. So what are your thoughts?
Well, maybe I'll just go with the example of like the Canadian Medical Association apology last week. I feel like we're just getting started when it comes to this kind of work in a lot of different healthcare spaces, because we're just starting to acknowledge a lot of the harm. And I can only speak for like physician settings, but I would suspect that it's probably just getting started in a lot of different areas. So I think there's lots of work that needs to be done still. Yeah, we still need a lot of help and a lot of different work. I feel like in the past 10 years, even since I've been in, you know, gone through medical training and then practicing as a physician, like the awareness has gone up a lot. I think with all the different reports that have come out, that's been helpful. But then the action phase of like what to do next is really just getting started.
Thank you for that. And Kathy, I know there were some questions in the chat asking about resources, and I wonder if you want to just spend a minute or two telling people about some of the resources.
So when CHCPBC amalgamated, unfortunately, our website was put together with sort of the key, what was considered to be the key pieces that needed to be on the site on day one of the amalgamation. And one of those things that is still missing but is underway is creating cultural safety and humility resources, which used to be on the legacy websites but didn't get ported over to the new website. So in the next few weeks, there will be a more added content around cultural safety and humility on the webpage, along with a whole bunch of resources that will address some of the questions that are in the chat now. But I will say there are a lot of places you can go to find the learning that you're seeking. The questions are broad. Somebody is asking about where you can find out about trauma-informed care. Someone is asking how you can find out more about the experiences of Indigenous people in the healthcare system. Each of those questions is unique, and so sometimes it's a little bit about figuring out what you want to learn today and going and finding that resource for yourself at the level that makes sense to you, because of course some people are early on their learning and unlearning journey and some are further along, and so I don't think any one list is going to satisfy everybody's questions. Yeah, I guess I'll leave it there and see if there's any thoughts from the
I wondered, just because some of the questions were about, you know, asking about more information around evidence of discrimination and racism in healthcare, that the In Plain Sight report is really a very compelling report to read. And so I would encourage people, I think it's actually linked within the standard, I believe. But if not, I think even Googling In Plain Sight will bring that report forward. And that's a really excellent place to start.
I did answer one question in the question and answers and made that answer visible to everybody with a link to the full report. There's a summary report, but I would recommend reading the full report, actually hear the testimonies of the Indigenous people who contributed to it.
Okay, Kathy, I'll just turn it to you to close and thank our speakers, because it's 1:30.
Thank you. So I don't know what to say today about this conversation. I think it's just the beginning, and I'm so thrilled to see everybody engaged in asking these questions. I'm so grateful to our speakers for being willing to answer some of those really difficult things. But I will say, sitting in that discomfort, both on the speaker's side, but also I would say as a learner and unlearner, these questions are not easy. These conversations are not easy. You need to be ready to be listening and vulnerable to the answers. And it doesn't feel nice to hear about these things, but that's part of the learning. So thank you so much, Dr. Rebekah. Thank you, Robin, for being willing to take this on. I think this reinforces for us that this conversation has to continue in some way. And we encourage all of you to reach out to CHCPBC if you have additional questions that were not addressed today. I did not get to all of them. There are lots of really good ones that are remaining. And so please reach out, and we're happy to have those conversations and direct you to specific resources if that's helpful. Thank you all, and have a great rest of your day.
Thank you, everyone.
Thank you.
Thank you.